So now we have an IC on spasms and palsies. So this is all about the abnormal periocular and the facial movements and how to manage them. And we know we have Botox for them, but what will we do when it fails? And also about the other end of the spectrum, that is when there is no innervation, that is in case of facial nerve palsy. So let us start with the first talk. For our first presenter is Dr. Soumya. She finished her oculoplasty training from Agarwal Eye Hospital, Chennai. Now she is working as an oculoplasty consultant at Chandraga Netralaya and Puttalat Eye Hospital. Welcome, Soumya.
Thank you. Welcome all. Good morning. I'm going to talk about facial dyskinesias, the abnormal facial movements. What are the types? How can we identify them? And what are the muscles involved? So these are the types: orbicularis myokymia, dystonia, which include blepharospasm, oromandibular spasm, Meek syndrome, hemifacial spasm, apraxia of lid opening, and rare things like aberrant regeneration of the facial nerve, psychogenic facial movement disorders, facial tics. So, little more about dystonia. Dystonias are sustained or intermittent muscle contractions causing abnormal, often repetitive movements, postures, or both. The 2013 update classified dystonia into isolated and combined depending on the etiology. In isolated, there won't be any neurological or systemic signs. In combined, there will be any systemic or neurological abnormality. Also, depending on the part involved, it can be divided into focal dystonia or segmental dystonia. Focal when there is only one part of the body is affected, like blepharospasm or oromandibular dystonia, and segmental when there is two or more body parts, continuous body part affected, like Meek syndrome. So the other types are aberrant regeneration of facial nerve. This is because of misdirection of the regenerating nerve, which are supposed to supply the orbicularis, supply the other parts of the face. So there will be voluntary during the voluntary eye closure, there will be involuntary lip movements. There will be sometimes decreased lid height due to orbicularis contraction. Psychogenic facial movement disorders are very rare, which are unwanted movements of the body parts due to underlying psychological disorder. Facial tics are complex, coordinated, multifocal movement patterns and switches between right and left side of the face. Example is the Tourette syndrome. So this is a little bit about the facial anatomy. These are the important facial muscles. The first one is the frontalis one, which pulls the eyebrow up, and corrugator superciliaris and procerus, which pulls the eyebrow medially and downwards. Orbicularis oculi will help in eye closure. Levator labii superioris and zygomaticus major, minor, everything helps in upward movement of the lip. Orbicularis oris help in mouth closure. Rhizoris help in lateral movement of the angle of the mouth. Depressor anguli oris and depressor labii inferioris helps in the downward movement of the lip. Platysma helps in the downward movement of the mandible. So the orbicularis has three parts: pretarsal part, which is just above the tarsus; preseptal part, anterior to the septum. These two help in the reflex contraction of the reflex closure of the eye, and orbital part help in the voluntary forceful closure of the eye. So just move on to the different types of spasms.
You can see spontaneous, gentle
Sound.
You can see spontaneous, gentle, constant, rippling contractions of the lower lid orbicularis oculi muscle here. It lasts for few hours to few weeks. So the muscle involved in this condition is orbicularis oculi muscle, and the condition is called orbicularis myokymia. It is mainly due to stress, fatigue, caffeine and drugs like topiramate, clozapine use. The key to the treatment is adequate rest, reassurance and avoiding the offensive substances. If it is persistent more than 3 months, it is called persistent myokymia, and botulinum toxin injections can be tried at this time. In this patient, you can see bilateral synchronous spasms of the muscles around the eye producing exaggerated blinking. So in this patient, the muscles involved here are orbicularis oculi, procerus and corrugator superciliaris. Unlike hemifacial spasm, blepharospasm abates during sleep and decreases with activity. The eyebrows are pulled down here, known as the Charcot sign. The causative mechanism is explained by Anderson as a three-component loop. External stimuli forming the afferent limb, a central control, and the muscles forming the efferent limb. When the self-limiting loop is disturbed, it produces blepharospasm. The treatments are botulinum toxin injection, medication, and myectomy. This patient has mild blepharospasm, but after installation of topical anesthesia, she looks better. So this is a case of secondary blepharospasm due to ocular surface disorders. We can see the spasms of this patient is mainly involving the lower part of the face, which is known as the oromandibular dystonia. He also has blepharospasm, cervical spasm. So this is a case of Meek syndrome. This patient has involuntary clonic muscle contractions of the one half of the face. Also notice the eyebrow of the ipsilateral side is little high. That is known as the Babinski-II sign. So this is a case of hemifacial spasm, which is caused by compression of the facial nerve leading to demyelination and aberrant signal conduction. It can be also due to intracranial mass lesions, so MRI and MRA of the head and neck should be done. There can be sometimes bilateral hemifacial spasm, which will be asynchronous in both sides. Also, Babinski-II sign will be positive. The treatments are botulinum toxin, oral medications, orbicular myectomy and surgical decompression of the facial nerve. This patient is not able to open his lids following eye closure, and we can also notice frontalis muscle contraction there, but once he opens it with hand, the eye closure and opening is normal. So this is a case of apraxia of lid opening. There is involuntary inhibition of the levator function, prolonged contracture of the orbicularis or both. It is usually associated with blepharospasm, Parkinsonism, drugs and CNS lesions. So CT or MRI is mandatory. The treatments include botulinum toxin and myectomy.
So to conclude, to diagnose the spasms, we can divide the face into 4 quadrants with vertical and horizontal midlines. So if it is involving only the one upper part of the one quadrant, it will be orbicularis myokymia. And if it's involving 2 quadrants of the same side, it will be hemifacial spasm. In that, you can notice the eyebrows will be in the little higher position, known as the Babinski-II sign. So if the 2 quadrants of the upper part of the face is involved, it will be blepharospasm. In that, the eyebrows will be pulled down because of the orbicularis contracture. And if the whole face is involved, it can be either Meek syndrome or bilateral hemifacial spasm. In Meek syndrome, there will be oromandibular dystonia, blepharospasm and cervical spasms. And bilateral hemifacial spasm, both sides of the face will be asynchronous and there will be ipsilateral elevation of the eyebrow. Thank you.
Thank you, Dr. Soumya, for that wonderful presentation. It was all well covered, all the facial, with almost wonderful, all the videos. Now and I think the discussion part, we'll keep it to the last. Okay. Now I invite Dr. Anju Chandran for the next talk. She is currently the oculoplastic consultant and academic in charge in Compress Eye Hospital, Calicut. I welcome Dr. Anju. She'll be talking on botulinum toxin.
Yeah. Thank you, Shebin, for this invite. It's always a pleasure to be a part of a group like this, and thank you, KSOS. So, Saumi has made my job much simpler because she has given a detailed graphic representation of all the disorders. So I have no financial disclosures whatsoever in the presentation. Okay, so what do these two gentlemen have in common? Can anybody volunteer? Obviously, they belong to two different eras, which is very clear. And the person on the left is Justinus Kerner, and he is the reason why the person on the right, whom we all know as Badshah, is still looking young. So, Dr. Justinus Kerner is the one who diagnosed and described botulinum toxin or botulism for the first time in the 19th century. So talking about the toxin, it is derived from a gram-positive anaerobe rod, which is Clostridium botulinum, which is usually present in plants. And its first therapeutic use in ophthalmology was described in 1981 by Alan Scott in Spasms. It has gained FDA approval for use in ophthalmology. If you were to look at the mechanism of action, it integrates with, it acts at the presynaptic neuromuscular junction, where it integrates with the presynaptic vesicles and prevents the release of acetylcholine, which prevents the transmission of, which prevents the neuromuscular transmission, thereby causing a neuroparalysis in that region. So the onset of action is basically beginning from 3 days, and it peaks at 3 to 4 weeks, and the duration of action is usually for 4 to 6 months, which means you need to give repeated injections. Different subtypes have been described, of which the most potent one is botulinum toxin A, and the other usable varieties are botulinum toxin B as well, and two commercially available types are botulinum toxin A, which are available in different brand names. The therapeutic indications in oculoplasty is what we will be dealing with today. So as Soumya already spoke in detail about the various facial dystonias, I will not be going into the details of the same. The other indications would be in upper lid retraction, such as in thyroid eye disease, and in exposure keratopathy, lower lid spastic entropion, and aberrant seventh nerve regeneration, where the patient usually complains of epiphora, in which case botulinum toxin will be very useful. Similarly, lacrimal hypersecretion due to various causes such as punctal stenosis, canalicular block, etc. And of course, cosmetic purposes. So the contraindications are, it should differ from use in patients with peripheral motor neuropathic diseases such as myasthenia gravis, as the effects can be debilitating, leading to even death. And it should be used in caution in patients with amino acid antibiotics or other agents. And you should look for any inflammatory or infective conditions in the area of injection. And since the effects are unknown in pregnancy and lactation, better to stay away from administering the same. Like I mentioned earlier, several preparations are available, and it's available in different varying concentrations, starting from 50 units to 100 to 200. And the one that I like using is Botox, which is available either in 50 or 100 units, and it comes as a freeze-dried formulated preparation, which needs to be reconstituted before use. And it is good to note that there is a cold chain that has to be maintained right from acquiring the drug to preparation and use till administration. So this is a brief video showing how you need to, how you can prepare, for which you need 0.9% preservative-free normal saline. Depending upon the concentration that you are comfortable with, you can dilute it. I like using 2.5 international units per 0.1 ml. Like I mentioned, the cold chain needs to be maintained throughout. So while you are preparing, as well as while you are mixing the saline into the drug, you need to make sure that you do not give vigorous movements, because this can destabilize the drug and lower the efficacy. So an informed consent needs to be taken prior to the procedure regarding the complications and the effects that the patient should expect, and also that the need for repeated injections need to be explained to the patient. Preoperative instructions such as stopping anticoagulants mainly because to prevent any ecchymosis or post-procedure bleeds, use of green tea and anti-inflammatory medications. One should note that a cumulative dose not more than 100 units should be given over 12-week period. So I will not be going into this because Sami has already covered that. So this is a patient with hemifacial spasm. As you can see, here we are administering with the use of a 30 gauge needle. Prior to the procedure, the patient was prepped with numbing cream. In this case, we have used a prilocaine cream, which is applied and kept for at least 20 minutes before the patient is given the injection. And in the periocular region, since there is no subcutaneous tissue, we give a subcutaneous injection. As you can see that there is a small blood formation along the lids, and the other muscles, which are the deeper muscles, we pinch so that it is introduced into the muscle as such. So I still prefer marking the sites for injection. One, because it helps, it eases with the administration, and second thing, it also gives me a track of how much unit I am inserting at the same. So in a patient with hemifacial spasm, usually we give 35 to 50 international units per sitting. So this is a patient with benign essential blepharospasm. This lady was in distress because she had to depend upon her children for her daily activities. She in fact came in a wheelchair and said that it has been months since she was able to do anything on her own. And this was her following a post-botulinum toxin injection. In her case, we gave mainly in the orbicularis oculi muscle and also the procerus and the corrugator muscle. And cumulative of usually 50 units is given. And now she is very happy and she is waiting to get out of her wheelchair and start losing all the weight that she gained over these days. So this was a patient with corneal ulcer. So in his case, what we have achieved with an injection botulinum toxin is to induce a complete ptosis, which gives time for the ulcer to heal over the period. So in this case, we have given a transconjunctival injection into the LPS muscle. Depending upon the effect that you need, around 5 to up to 10 units can also be given for the patient. So this is lacrimal gland injection that we are given. In this particular patient, she had a canalicular block, common canalicular block, and she was distressed by the epiphora that she had. So care needs to be taken that you should be able to visualize the lacrimal gland well before you inject. Again, prior to the procedure and post-procedure, you need to keep a track of the tear production, which you can do by various tests. And you should also warn the patient that post the procedure, initial period, there will be severe dryness for which lubricants need to be given. So here around 2.5 to 5 units can be given per lacrimal gland. This was a patient with an upper lid retraction and thyroid eye disease. He was already receiving treatment for active thyroid eye disease, and here in his case we have given injection into the LPS muscle to induce ptosis, lower the retraction in both eyes. And in this particular case, as you saw, we have given a transconjunctival. You can also give a transcutaneous one into the LPS muscle right away. So in entropion, the definitive treatment, as we know, is surgical management, but you can use botulinum toxin to basically buy time for the patient, or prior to cataract surgeries where the patient is waiting for has been advised to undergo, like in mature cataracts or hard cataracts. Again, it is short-lived, so the patient has to undergo a definitive surgery. Cosmetic indications are various, such as for the forehead lines, for the bunny lines on the nose, for crow's feet. What you can also achieve is, in this particular patient, if you can see bilaterally, there's a slight hooding and the patient is bothered by the dermatochalasis. So we have achieved what is called a chemical brow lift by negating the depressors and injecting a bit into the tail of the eyebrow. Similarly, the forehead lines were also gotten rid of by injecting botulinum toxin of 2.5 units at multiple sites at the presence of the mounds or the furrows that you can see, because those are where the muscle bellies are. And this is the resultant effect. So postoperative care is, especially in lacrimal gland botulinum toxin, you should ask the patient to avoid lying down for at least 4 hours, because you do not want the medicine to track elsewhere and cause ptosis for the patient. And also in patients who have undergone injections in the periocular region or in the face, it's better to avoid face massage at least for a week. Complications, we can divide them as injection-related and neurotoxin-related. Injection-related, as in any injection, would be pain, infection, and ecchymosis. And neurotoxin-related, most common would be ptosis. But you can assure the patient that it is transient and then it will slowly get back. And diplopia, if it has tracked into the extraocular muscles. Lag of thalamus, as you can see in that patient who received for upper lid retraction. Midfacial weakness and dry eye, for which you invariably put all your patients on lubricants, even in patients with hemifacial spasm and benign essential blepharospasm. So with that, I end my presentation. Thank you, Shebin. Thank you all.
Thank you, Anshu. It was very well presented and all beautiful results. Okay, next we have Dr. Marian Poli. She is the head of the Department of Oculoplasty, Ocular Oncology and Orbit, Giridharai Hospital. Madam will be presenting on the what we will do next when the Botox fails. Welcome, ma'am.
Thank you, Dr. Shepin, for the opportunity. And primarily this session is called orbicularis session. We are basically discussing on one side it is paralysis, on one side it is overaction. So session on orbicularis. So when botulinum toxin fails, there are many options. Either we can do surgery or a pharmacotherapy or photochromatic modulation. So what is photochromatic modulation? We know most of the patients come to us when they go to the light, their spasms are getting much more and they can't even open the eyes. So this is sunglasses always we prescribe, but that is not really very effective. This is special lens, that is FL41 lens tint, and it is rose colored. I tried my level best to get in India, but actually it is not marketed in India. It is in US and UK, and some relatives they can get them for the patients. These glasses were given to patients with migraine headaches, because migraine, when they are exposed to very severe light, they will get migraine attacks. The mechanism is this glasses increases the intensity of light that blepharospasm patients can tolerate, and also reduce their eyelid blink rate. So this is actually very useful if you can get it. So if you see the botulinum toxin is not really working well or they are not very happy, the next thing what I do is like get an opinion from the neurologist, primarily to see any medical management would be a help to him. Especially dopamine agonist, GABA agonist and anticholinergics. The problem is the disadvantages, like there are all those sedation side effects. And when I send a neurologist and they take medicine for 1 month, patients will come back and tell, doctor, after taking that medicine, I can't even get up. So no reason for going out. So that's the problem with all these neuro medications. So most of the time, they will not tolerate the medicines. So coming to surgery, the indications are apraxia of lid opening associated with the blepharospasm, true failure of Botox, and patients who refuse Botox injections, or those who cannot afford injections in every 3 to 4 months of life, or like 6 months. So in my practice, primarily 1 and 3 forms the major indications. True failure of Botox is extremely very rare. It is seen only in less than 2% of cases. And to assess the failure, you can inject 10 units of Botox in a forehead, write it, and see the response. And the patient is, if no response, that means the patient is immune or refractory to the toxin. So what is the aim of the surgery? The surgery is basically removing the orbicularis, that is orbicularis myectomy. You cannot eliminate the full spasms because 100% cure you cannot offer at all. So the aim of the surgery is to improve the functionality in patients affected with blepharospasm. That is, for example, the people who are drivers, they can't drive in bright light. So the aim is to make them drive. Then reduce the severity of the spasms. Some patients will blink very forcefully. So in that case, you can at least reduce that severity of the spasms. Then third thing, you can increase the period between botulinum injections. So it reduces the hospital visit as well as the financial aspect also. The fourth thing is it improves the associated eyelid changes found in patients with blepharospasm, like ptosis, redundant skin, broad ptosis, etc. So these are the main aim. This we have to tell the patient beforehand, because most of the time patients will come and ask you, is it 100% sure? So you cannot offer 100% anyway. Coming to surgery proper, myectomy can be combined with levator reattachment or frontalis sling or brow lift and blepharoplasty. So all the photo is very familiar in this session. So primarily we are removing the orbicularis as well as corrugator and procerus. So coming to the surgery. Surgery is a very long surgery because lid crease incision. Either you can use radiofrequency cautery or number 15 blade. Then separate the muscle. Here I am separating, incising preseptal from the pretarsal. So now I am moving to the pretarsal orbicularis and stripping off the pretarsal orbicularis with radiofrequency cautery. The incision should go up to the lash bulb. Care should be taken not to create holes in the skin. Then move to the preseptal area. Again, care should be taken to avoid injury to the septa. And remove the preseptal orbicularis. Then go to the lateral raphe. That includes orbital part of the orbicularis also. So lateral raphe orbicularis is removed. Then go to the corrugator and procerus. This area is very vascular because the preorbital nerves and vessels pass through this. Then you can complete with either levator reattachment or frontalis sling. I prefer frontalis sling because if some residual spasm comes, again levator is into action and ptosis can increase. So I prefer frontalis sling in this kind of cases. If you want to combine blepharoplasty, that can be combined. And the frontalis sling is done in the regular Fox pentagon pattern. Post-operative period, even though, in the post-operative period, lots of lymphedema will be there. So I usually put drain, and drain will be removed after 1 day. Then ecchymosis, allosis will resolve in 3 weeks' time. I combine both lids together, especially upper lids. Lower lid I usually do in the secondary sitting if needed, because doing all the 4 lids together is really very cumbersome. It takes too much of time also. So have done a couple of cases. All the myectomy patients are really doing very well. They are functionally very happy. So this is a patient. You can see the both pre and the post-operative videos. So first is the pre-operative and the second is the post-operative video. The improvement in the spasms as well as the blink. So he was actually a driver and he couldn't drive because of his spasms. So post-operatively he could do his job and he is happy and he still comes for follow-up even after 7 years. In this I have combined myectomy with the frontalis sling. So in another case, frontalis suspension alone can be done. So now you see the spasms on the right side as well as the left side. Frontalis suspension alone versus combining with the myectomy, it needs further study, to be frank. So some cases I do frontalis suspension alone. That depends on, he's actually a very old man. He doesn't go out, but only he wants to read. So that again depends on the patient's functions also. So in this case, I did suspension alone and he is doing well at 6 months follow-up. Literature review, see, myectomy was very commonly done before Botox. So once Botox came, actually, since the Botox was working very well and the need for surgery was very less. So in all the studies, full myectomy shows around 88% of improvement. It's a very old article published in 1998. And in another article published in 1999, the 5-year probability of Botox is 46%, but the dose is very less. So in all aspects, myectomy works well. Only thing, the cost of the surgery and the time, this is a very long duration surgery. So you have to outweigh Botox versus myectomy, but it really works well. Coming to the next spasm, that is hemifacial spasm. Surgical management, Botox we have listened from Dr. Anju. Microvascular decompression is very commonly done. Sometimes immediate results are very good, but long-term recurrences are common. But again, here also it is done by neurosurgeons, skull-based surgeons, but outcomes are not really predictable. So that is again, here also again the cost versus complications of surgery matters. So to conclude, myectomy will definitely help in benign essential blepharospasm versus ALO, and very gratifying results. It improves the quality of life. That's the most important thing. Another thing is it will reduce the hospital visits. Like this is a lifetime disease, and they have to visit the hospital every 6 months. Not only the patients, the attender, then the transportation charges, registration fees. So combining everything, I think surgery works better in the long term. And even if some residual spasm is there, the dose of Botox which we give is very less. So I had 1 or 2 patients which I do give little bit of Botox, like 6 units after myectomy, because they are all people like teachers, bank managers, that kind of professionals. So thank you so much.
Thank you, Dr. Marian, for that wonderful presentation, as always. Next, I think we'll move on to the discussion part before the last one. Okay.
Any doubts? I'm sorry, I'm committed in another session for PG. Yeah. This is, no, they will do well. They will do well. Yeah, actually sling also need not do, but like, sometimes when they get become very old, this aponeurotic ptosis might cover something. So I will just combine with the sling so that 100% safe. Fox Pentagon. Open sky.
That was good.
Yeah.
And one more thing, Botox, if you repeat very frequently also, it won't act.
Yeah.
It is said that they develop antibodies. And once a year, how frequently do you give Botox?
6 months, 9 months.
Yeah. I think RCC people give every 3 months.
Yeah.
And do you keep the Botox after the thing?
I keep after dilution.
No, I know, up to 2 weeks, or
No,
can you
before that-
freeze and use it? Has anybody done that? Can you freeze and use it again? 3 months, it's okay. Okay, yeah. 3 months, -4 degrees, that is in the fridge, no? Okay. Yeah, even. Yeah, we also, but when I go to another, where there are few patients, I told them to freeze, but I don't know, for canalicular block, we have used after freezing, but that's small units, I don't know if it is effective or not effective.
Freezing, I'm not sure, but at 4 degrees Celsius, 3 months, ma'am, we have stored max and it works well. Though literature there's a paper by, I think, Dr. Shom and et al., and they say up till 6 months also the Botox efficiency will not change if you store it at 4 degrees Celsius. But no
don't know,
experience
yeah.
with that. One more
I
thing,
don't know if they are biased also.
one more thing I'd like to ask you, ma'am. Do you even remove the corrugators?
Yeah, I remove
Procedures and the corrugators as well, yes.
Sometimes some anesthesia, it is only temporary what I have seen, but I remove. Otherwise, the results I don't know. In initial cases, I didn't remove, but they had little bit of residual spasms. Then I had to, yeah.
I've removed.
Yeah, I keep drain just to prevent hematoma, because hematomas on day 1, day 2 is very, doesn't look very nice to the patient and to the attendant, not only to the patient, its attenders are really scared of you. Doctor, will it go? All those questions will come, so.
I actually mix the dexamethasone along with xylocaine, so the poster of edema is a little
Even
less.
5FU, they have started using, in OPRS there was an article, it prevents fibrosis, adherence, all those things, but it's okay.
Nice, ma'am, very nice video.
Thank you.
Ma'am, sorry, one last question. Any incident of lag of thalmus?
No, there is no lag of thalmus after myectomy, and that's 100% sure. And initially, you will keep frost suture for 1 week. I'm putting on with the sling, so I keep frost for 1 week. Then no lag of thalmus. Little bit lag of thalmus, 1 millimeter, 2 millimeter, that will improve at 4 weeks time.
Thank you, ma'am. Thank you so much.
Sorry, I had to.
Thank you.
Any unusual questions?
So, next, Anju, I have a question. So, any side effects you have noticed after giving these Botox injections?
Initially, when I started giving botulinum toxin, I noted that there was lag of thalamus for the patients. So maybe improper technique would have led to that. But now patients complain of minimum lag of thalamus and associated problems. Another thing, one of my patients for whom I had given a lacrimal gland botulinum toxin, he complained, he came with bilateral ptosis.
Yes, that I want.
So bilateral ptosis, this particular patient, what I noticed was he had deep set eyes and the lacrimal gland was a little tricky to identify. In the hindsight, I felt I should have taken him up in the operation theatre and then everted the lid and exposed the lacrimal gland and probably would have done a better job. So these are two complications that I felt, and like when we store, I've noticed that for me at least 6 weeks and beyond, the efficacy starts to come down. So the patients come back sooner for a repeat injection. So that's my experience. So far not.
Also in that, the picture you have showed in the thyroid patient, that is a very good correction. No ptosis, but the lid retraction was beautifully corrected. So in those patients, is it possible to get a more ptosis? That how to titrate your dose?
Since that was my second patient in whom I had done, the first patient I didn't get adequate correction because I had given a transcutaneous one. In this particular patient, I gave a transconjunctival one, both medially as well as laterally. But like you said, it's with injections that you decide on how much each patient requires. This patient, a total of 7.5 units was what I had given. So his correction I was happier with.
So you do an imaging before giving for TED? So in what I have noticed is if there is activity, then you can give a triamcinolone acetate, then followed by a Botox after 1 week, that would help better. If there is no activity, then probably, at least in my cases, Botox was working okay, but very unreliable, very unpredictable results.
So the problem is most often patients with active thyroid eye disease, at least in our setup, most of them have associated glaucoma as well. So I have my reservations about giving triamcinolone in those patients, so I resort to botulinum toxin more.
So another question is glaucoma, do you see glaucoma in such patients wherein the triamcinolone was given to the LPS? Is that common?
Not really.
There is a possibility.
It acts as a depot, and as ma'am said that it's in the lid. So we have not really observed that much. The systemic absorption is also very minimum when you give it as a depot in the lid. So not much.
And one more thing, which is the preferred route? Is it the transconjunctival or the transcutaneous?
I think it's subjective. That is in the surgeon's or the injector's hand.
I think it's subjective, whatever you're comfortable with, as long as you don't go and poke the globe.
So yeah.
One question to Soumya. So this I have seen in few cases, in early stages of hemifacial spasm, they will have very limited spasm, mostly only to the orbic. So but later when we see that patients, we can see that they're progressing to hemifacial spasm, like full. So in those patients, how to avoid a confusion between the myokymia and whether to take it as hemifacial spasm?
There are reports like myokymia leading to hemifacial spasm. So always keep a track of your patient, even if it is looking like simple myokymia. Ask them to review back if it is persisting more than 2 to 3 months, and follow up and see whether if any extra muscles are acting that time.
Ask the patient for a photographic record, because if in case he's not able to come back for a review, he can always see those consecutive videos to you. Those make it very easy for us clinically also to have a record for ourselves and to assess the comparison.
I have a question to ask both Dr. Aparna and Dr. Sonam. So do you advise MRI brain imaging in all patients with hemifacial spasm?
So mostly when the patient sometimes comes to us, he has already visited the neurologist. So a basic comprehensive neurological examination has already been done. So such patients do come back with an MRI. In addition to the report, if we are interested in more of a periorbital study, then we can always ask for a reporting from the radiologist. But not all, if primarily come, we will assess them clinically, and then in case we feel, we will advise. But most of our patients come through a referral already.
I think we advise, but based on the history. If you already have a history of facial nerve palsy, or you have some CP angle tumor which has been removed, there is a facial palsy there and there might be some aberrant regenerations, then you might not really require to do it. But if it is the first time the patient is coming without a history, then I would prefer, especially if it's a young patient, then why not? Because if there is a compression, microvascular decompression has good results in younger patients. So it's always better to know the cause. So I would advise, though I know it's financially this thing, but. Okay, Anima, what is your opinion on this?
Most of the patients who come with very mild spasm, lower lid and all that, no, you ask them, they have lost some sleep, they are under tension. If you give some drops, tell them to relieve the tension, doing yoga. All that will make it disappear. I have had my own relative had that. So after that, if you want for mild irritating spasms, you can give orbicularis. What did you ask?
And also regarding imaging in case of...
Imaging, mostly we have a neurologist. I don't do routine imaging. Patient is, what is the use of any patient? Did you get any finding after imaging? I don't think so. Nothing that we can correct, no.
Actually, one of my patients had some cisternae, fourth ventricular cistern.
HFS not resolving even with botulinum toxin, maybe like around 6 weeks max effect. So we thought maybe it's a Botox problem, but then he said he'd got imaging done previously, and we reviewed it. That time nothing was there. Then when we repeated a fresh imaging, he had a long-standing history of some 7-8 years, and then there was some like fourth ventricular cisternae, some issues in the brain, and then he had to undergo surgery for that. So that was one patient out of so many patients that we found something. But other than that, only the loop which is compressing over the 7th nerve at the points. That's the main finding, ma'am. So these rare things.
Do you do myectomy for what are your patient?
Actually, ma'am, we have a grading that we follow, the dystonia grading which is there. If they fall in the grade 3, grade 4, grade 5, which is affecting the QL, also the severity is more, then we do, ma'am, myectomy.
For hemifacial spasm which is not responding
HFS, we have just done for, I think, 1 or 2 patients. We've not done.
Was it effective? No.
Dr. Nirmala has done for 1. I have done for 1. It was effective. The main thing was also, one of them was a plastic surgeon who had come, and her main thing was when she's talking to the patients, she doesn't want to keep putting Botox frequently, and patients think that she's winking constantly at her. So for her, it worked very well. She was very happy post this. This patient was operated by Dr. Nirmala. So I've seen her post-op, I've seen her recovery. She was very happy. The patient that I had operated, he's also doing fine. But like you said, ma'am, they come back for follow-up after a long time. They're fine, they won't come back. Yeah. So that is the thing.
Your lag of thalmus not there, no much.
No, not much, ma'am.
I think we should do. I was thinking, why should we take off the whole orbicular? Can we give the cuts like this so that it won't act?
No, ma'am.
Easier for us.
If we don't remove the entire orbicularis, it is still going to spasms will persist. So we have to go all the way till the orbital component, remove everything.
Just to remove it, just give cuts so that it don't act together. Just my idea, I don't know. I didn't try, I have not tried.
We can try, ma'am. Thank you.
I think next we'll move on to the last session of the IC. I welcome Dr. Shebin. She is actually a consultant, oculoplasty consultant in Giridhar Hospital, Cochin. She'll be talking on tackling the corneal exposure in a case of facial nerve palsy.
Hello. So till now we learned all about the excessive movements or the abnormal movements in the periocular region. So let's go to the other extreme. That is, in case of facial nerve palsy, what happens?
So the result is devastating with significant functional and cosmetic impairment. So I'm not going into the etiology which we all learned yesterday in different sessions. So our primary concern is here is prevention of visual loss secondary to exposure keratopathy and corneal ulceration. A full eyelid closure with a normal blink reflex is necessary for the maintenance of a stable tear film and a healthy ocular surface. With being said that, we have so many methods to correct the lag of ophthalmos or manage facial nerve palsy, which include supportive treatments and surgical, non-surgical methods, which already Anju talked about few of them. But the problem with all these methods, they do not bring back the normal blink reflex, or even to some extent they correct the lag of ophthalmos, but not fully. Also, one significant side effect is that they sometimes reduce the, not all procedures, but when we do the tarsorrhaphy and all, it reduces the width of the palpebral aperture. So how can we improve? How can we bring a more anatomical correction to the patient? How to regain the blink reflex? So there comes the dynamic methods. When it comes to dynamic restoration of the facial activity, transferring muscle fibers from one region to another with its own nerve supply, that is the principle of dynamic facial reanimation. So till now we mostly used temporalis muscle transposition, that is the most commonly performed muscle transfer procedures in facial palsy. But what is the problem with temporalis muscle transfer? Because it mainly, when the temporalis muscle is transferred to the orbicularis oculi muscle, it depends upon the mastication for a eyelid closure. So at night it will again a problem, because at night we do not chew. So again the lag of ophthalmos will remain. And then came two main observations, that is lack of any significant clinical side effects on removing the preseptal orbicularis oculi following blepharoplasty, myectomy. Also, there was another observation, that was the medial lag of ophthalmos that was noted following deep dissection at the medial cheek or the nasofacial groove. So that suggested a medial buccal nerve supply. So till now, conventionally, we thought that the orbicularis oculi muscle is supplied by the superficial temporal and the zygomatic branches of the facial nerve. But then this observation led to the medial buccal nerve supplying to the orbicularis oculi. So there comes the medially based neuromuscular pedicled orbicularis oculi muscle. So an anatomical study was done on cadavers. So what they found here, we can see that it is marked by this green color. So there was a terminal ascending branch that traveled in the superomedial fashion to innervate the orbicularis oculi muscle medially. And it also has a vascular pedicle along with it, that is a supratrochlear artery. So that supplies the orbicularis. So if we can raise a flap of orbicularis that is like based medially, we will not be interrupting the vascular or the nerve supply. So that is the basis for the dynamic muscle transfer of orbicularis oculi muscle. So what we are doing here we are creating a flap of orbicularis oculi muscle, wide flap, that is very important, of about 10 millimeter that we are taking from the healthy side and transferring to the normal affected side via a subcutaneous tunnel that was created through the dorsum of the nose. So let us see the video here. Sound is there. Traction suture is applied. Skin crease incision is made on the donor side. The preseptal orbicularis oculi muscle is identified and exposed by undermining the skin. The desired width of the muscle is 10 millimeter. A flap of healthy orbicularis muscle is raised, remaining attached medially via a wide pedicle, not to interfere with its nerve and vascular supply. Then a subcutaneous supranasal tunnel is fashioned through which the orbicularis flap is passed to the affected side. The orbicularis muscle flap is then divided into superior and inferior slits, which are then tunneled through the subcutaneous plane to the lower and upper lids. So here the muscle is sutured into the pre-tarsal orbicularis on the affected side. And are respectively sutured into the paralytic orbicularis on the affected side using 6-vicral sutures. The skin incisions are closed with 6-vicral sutures on either side. So this is the immediate post-operative appearance of the patient. So this was a pre-operative video. It will show how much she had lag of thalmus, and it was about 5 to 6 millimeter. So let us see what is the post-operative appearance. So this is the post-operative. Here we can see that even she has a blink is also restored, not to the full extent as the normal side, but yeah, there is significant improvement, and the lag of thalmus also improved significantly. Yes. So this is a few other patients whom we did the same procedure. This was another patient, but I'm not telling that only orbicularis transfer is done. In this patient, I did an LPS recession also, because in when this facial nerve palsy is long-standing, mostly the LPS muscle undergoes some kind of fibrotic changes or contraction. So that needs to be released, otherwise you cannot achieve a full correction. The complications so far, no major complications, but one important point is that when we are doing surgery on both sides, we cannot patch both eyes, because then the immediate postoperative patient will be having problems. So usually what we do is we patch on the affected side. But then what happens in the donor area, also we had done a significant dissection. So I had a patient in whom in the immediate postoperative period, she had a large hematoma. Though she was not on any anticoagulant or anything, but then I had to evacuate the hematoma eventually. So also the other procedures which I do along with this orbicularis transfer, performed under local anesthesia, lid crease incision is made, levator recession, orbicularis is incised, levator aponeurosis is exposed, septum is excised and removed. The levator muscle is separated from underlying conjunctiva, leaving a central 5 mm area still attached to upper border of tarsus. Separated muscle is excised. Careful to completely remove the medial and lateral horn of the levator for optimal result. Underlying conjunctiva is also incised if proceeding with a full thickness blepharotomy. Only skin and orbicularis are closed in layers. When it upper lid traction sutures are placed. When it comes to the lower lid, if it is only minimal retraction, then in the upper lid, we can do a mullerectomy also if you do not want to disturb the LPS muscle. This procedure we can do in patients with a minimal lag of thalmus and a minimal lid retraction. So this is a very safe procedure without any much of complications. And the lid is everted over a Demaris retractor. Local anesthetic is infiltrated to separate conjunctiva from Muller's muscle. Upper edge of the tarsus is marked. A unipolar cautery is used to dissect the conjunctiva off from the undersurface of the Muller's muscle. A traction suture is applied to the conjunctival edge to facilitate the dissection. Now local infiltration is done to create a plane between the levator muscle and the Muller's muscle. The Muller's muscle is then dissected off from the undersurface of the levator muscle and it is excised in toto. Fibrin glue is used to approximate the conjunctiva to the tarsus.
Okay, thank you.
Thank you, Dr. Shebin, for that wonderful presentation, and it was really a great insight into the non-conventional techniques for tackling the lag of thalamus. And with this,
Any doubts?
Attach the other orbicularis.
No, ma'am. In the affected side, the lid crease incision is not made.
Not made, just
only tunneling to the pretarsal part.
So how do you suture it?
Into the orbicularis with 7-vicryl.
Over the skin.
We made small incisions.
Okay.
Small incisions, yeah.
On the lid crease.
Yeah, like how we make for the sling.
So how long will it extend on the recipient?
It comes to about 1/3 to half the distance. It's difficult to convince, ma'am.
I'll start doing it.
I'll ask you how you choose your patients later. But very nice.
Yeah, when they suffer for a long time, they will agree for.
So all these are chronic cases.
Yeah, mostly chronic cases. Which has been operated also a few times.
So this would work basically for post CP angle tumors
This
where
will
the
work-
iatrogenic facial nerve
Yeah.
injury is there. So
They are the ideal cases where the House-Bragman score is
like
6.
paratic, correct. Correct, nice. Very good, nice.
Thank you.
I think with this we'll wind up this session. We'll move to the next one.
Thank you all.